Namaste and good afternoon. Greetings from all of us at Apollo Hospitals. This is Dr. Srinidhi Chidambaram, and I'm very happy to see you all again. I hope you've been well and in the best of health and spirits. And I hope you've been enjoying our Facebook sessions where we aim to give you factual information straight from our experts so that you can be fine tuned towards your health. Today, we're going to talk about something that is perhaps the most common symptom of potentially thousands of injuries, diseases, disorders, and conditions that you can experience in your lifetime. It can also result from treatments for conditions and diseases. It is pain. Pain can last a short time and go away when you heal, or it can last for months or years, affecting your quality of life. But today, pain management is a specialty by itself. Pain management specialists can help you control pain with medications, procedures, exercises, and therapy. To reduce and relieve pain, they may recommend one approach or a combination of many approaches. But what you need to understand is that in modern medical practice, there are many options to manage pain, and you should not be going through the agony of pain, whatever be the cause. So, today we're going to explore this topic and the specialty of pain management and understand what it offers, and also focus on one of the most common types of pain that most of us have, which is back pain. To discuss this, I am delighted to welcome Dr. Anand Murugesan. Dr. Anand Murugesan is a senior consultant in the Department of Anesthesia and Pain and Palliative Care at Apollo Hospitals, Greens Road, Chennai, Apollo Cancer Institute, Tenampet, and Apollo Proton Cancer Center, Chennai. He also serves as director of the Panacea Pain Management Center. He's the winner of the prestigious Dr. Kopp's Award issued by the Indian Society of Anesthesiologists in 2009 in postoperative pain management. He underwent fellowship training in chronic pain management in 2012 and 13 at the Center for Pain Management, Bowling Green, Kentucky, US, and the Advanced Pain Care Center at Evansville, Indiana, US. He also underwent a month-long training in Toronto, as well as a fellowship in interventional pain practice, and was certified as an interventional pain sonologist at King's College London in 2018. And his vast experience in this field has secured him the opportunity to be a speaker and panelist at the London Pain Forum and a faculty panelist and moderator for various cadaver workshops conducted in India. He also has several publications to his credit. Welcome, Dr. Anand, to this Facebook Live session. So let's begin by asking you, what is pain management?
Namaste. Pain management is a discipline in medicine, which is actually originated from the anesthesiology as a subspecialty, but eventually has become the super specialty now. Previously, the pain management was done as a symptom management. Like when you have pain, you have to treat the pain with medication. But it has grown leaps and bounds. Like now the pain management, like more than the symptom management, it is the disease management. So it has evolved in such a way, we need to identify the cause for the pain, the source of the pain, and then treat that. So unless we treat the cause for the pain is not going to be completely eliminated. So it is initially a subspecialty in anesthesiology, but now it is a super specialty. And as you rightly mentioned, it is the specialty on its own.
So, what are some of the common medical conditions that where pain management is usually deployed?
Degenerative diseases, like common problems we have in pain, we come across in pain management is like the lifestyle disorders, especially the chronic back pain, neck pain, shoulder pain, and headaches. So we are in an era like where we are all so busy with techies, technologies, and the advances in the technology. We are in the technological era basically, like where we are closely associated with softwares, televisions, laptops, mobile phones, and other side we are moving away from our healthy lifestyles, like more of a bench work or the table work or the the corporate work. So the lack of exercise, and that leads to the chronic pain conditions. So these are all the things which are coming to us very commonly, which is not just restricted to only the elderly population or the geriatric. Even in the middle age and younger population, they are coming due to these lifestyle disorders. This is one side, otherwise we call it as non NCDs or the lifestyle disorders. The other side, if you say it is now cancer, cancer is on rise and pain is a part of the cancer. And the pain in cancer is very, very, very dreadful. So, so the common one side is the life, we can keep it as a lifestyle disorders causing pain. The another side is a deadly cancer, which is causing pain. So most of the pain conditions will be falling in one of these two categories.
So, if somebody is living with constant pain, what do you think are the effects that it has on their own health and their well-being?
Yeah, this is actually a very, very, very important question, because the pain, what we call, what we all know is a physical pain, like it is aching. Pain is an
Yeah.
ache. But what happens once this pain lasts long? It is generally said any pain which is lasting more than 3 months, we call it as a chronic pain. Any pain which is lasting less than 3 months, we call it as an acute pain. So once the pain becomes chronic, which means once the pain lasts more than 3 months, it is not going to restrict only with the physical pain. There are other components which adds to it, like the psychological pain, the emotional pain, the social pain, the occupational pain. All these things will add together to the actual physical pain if the pain is not treated properly, or if the pain is underdiagnosed or undertreated, or if it is not treated adequately at the earliest. Once it becomes chronic, it becomes so challenging for the pain physicians to treat the patients, because this chronicity will add a lot of other components of the pain, what I mentioned. After that, it becomes so multidimensional. Just treating the mere physical pain alone may not be sufficient for the patient, where it becomes a multimodal or a multidisciplinary approach to treat the pain. So that's how chronic pain carries significance, where it is not just the physical pain alone. It is the psychological and the emotional components which adds to the physical pain, making the chronic pain management very challenging and difficult.
So, what are the common techniques that are used? For example, if it is a chronic cancer pain, or if it is a chronic degenerative pain, or in a post-operative situation. So, what are the different? So, what is it that the pain specialist will do differently as compared to what was traditionally practiced?
What was traditionally practiced is pharmacotherapy. We were in the era of opioids, where they're commonly given pain medication for either a post-operative pain or a chronic pain, or opioids. There are many opioids where it is generally given for treating the pain. How we evolved in pain management is we identified the opioids and its related problems or side effects, which is as bad as a pain. Patient comes to you for a remedy. They come with the pain. And in the process of treating the pain, we should not add up more problems to the patient who are already suffering. So in opioid therapy, what happens, like the side effects of the opioids, like vomiting, nausea, severe constipation, abdominal distension. So all these things makes very, very unpleasant for the patient to continue the medication or to tolerate the medication. So we have to have something which is opioid sparing. Opioid sparing means none other than opioids that relieves the pain, and thereby patients are not subjected to the side effects of the opioids. Because traditionally, any severe pain, previously it was managed only with the opioid therapy. So in the evolution, then we realized what are the good opioid sparing things that we can offer to our patients. Then we realized it should be more target oriented. You take a pill, you take opioid, for example, you take a morphine. You take it as a pill that goes to the stomach, gets absorbed in the blood, and it goes everywhere. And this can cause a systemic side effects. The constipation is a systemic side effect. And another problem, if you give the opioid in geriatric population, they'll be more drowsy, they will be like very dizzy, and they may have giddiness and fall and develop fractures. So they are all very adverse side effects of the opioids, which is actually speaking not really addressing the problem, rather making the problem more complicated. So then we evaluated, and then we thought the treatment, the pain management should be more target oriented. So then comes the interventional pain management. Interventional pain management is very simple. It target the nerves which supplies the pain generator. If any patient has pain, if someone has pain, there is a pain generator, right? Somewhere
Yeah.
from the back means it will come to the back later. So there should be a pain generator in the body that gives you pain. And that pain generator obviously has got its nerve supply. And these nerves are the one which are the conductors of the pain signals. Like how the electricity is conducted in a wire, pain is conducted through nerves. From where the pain originates, the nerves from there takes the pain signals to your spinal cord, to the brain, and brain senses, yes, there is a pain there, there's a problem there, and that senses back saying there is a pain, that gives the pain. So here the main problem, the problematic person here is the nerve that takes the pain signals to the brain and gives the pain. So in interventional pain, what we are doing is target those nerves which supplies the pain area and block them either temporarily or permanently, depending on the disease process. There are some nerves can be blocked permanently. There are some that can be blocked temporarily with frequent intervals so that the nerve gets modulated and the pain signals is halted. Thereby, the patient gets the pain. So this is an evolution. It's called interventional pain management that addresses almost all the pain conditions in the body.
So what about palliative care? So in cases where there is terminal illnesses, when there is pain, so how is palliative pain management done?
Palliative care is a big umbrella. In that, pain management is a part of it. Palliative care includes pain management, good dietary support, good physical therapy, and good mobility of the patient, good sleep. These five contributes to the palliative care. In that, pain management is one component, but which is predominantly an important component. In most of the palliative care patients are cancer patients. Of course, there are some non-cancer patients who needs palliative care, like chronic stroke patients, chronic neurological disorders like multiple sclerosis, Guillain-Barré syndromes. So they can cause a severe disability to the patient with severe pain and who also needs palliative care. So if it comes to palliative care, pain management, and especially the interventional pain management is an essential component. Let us come to the cancer. Cancer needs a palliative care. So WHO, the World Health Organization, has set up a very nice ladder. Initially, it was a ladder like we have a 4 steps: step 1, step 2, step 3, and step 4. Where depending, it starts with less pain. Like pain is classified into mild, moderate, and severe based on the pain score. So with mild pain, we'll be in ladder 1. If pain becomes little severe, like for example, moderate, then we have to climb up the ladder to step 2. And if pain becomes severe, then we have to climb to step 3. If pain becomes very severe, then we have to climb to step 4. So in step 1, we will start with very, very small, minor dose of medications like non-steroidal, like we know Brufen, diclofenac, pain bombs. Those are all the milder ones, anti-inflammatories we give at step 1 for mild pain. For step 2, like moderate pain, we have to give weaker opiates. For severe pain, we have to give strong opioids like morphine, fentanyl. There is step 4 that is called interventional pain. Initially, it was reserved for only for very severe pain. But World Health Organization now has revised the ladder, revised the WHO ladder and said that step 4 should be applied at any point of the therapy, of the treatment. Step 4 can be even before step 1, which means the interventional pain management in cancer should be the first choice. If patient accepts or if patient opts because of the target oriented treatment and to avoid the side effects of the polypharmacy medications, as I mentioned, like opioids. So palliative is this pain management is a part of the palliative care. Along with this pain management, we need to supplement the dietary support, psychological support, like with a good psychologist who can talk to them, counsel them about their ray of hopes in life with these chronic pain conditions they have. And of course, physical therapy, like where we need to give a targeted exercise and mobility, like walking and short courses of targeted muscle strengthening exercise like that. So this all contributes to the palliative care. So pain management is one of the component, which is a predominant component in the palliative care, which is offered to cancer patients and even non-cancer patients like chronic neurological debilitating patients.
So now we'll come to one common problem which many people face, which is the low back pain, which is now quite prevalent due to so many reasons, sedentary lifestyle or postural issues. So what is the contribution of pain management in back pain, and what causes this chronic back pain in so many people?
This chronic back pain is the biggest burden to the community now. Previously, it was affecting only above the fourth decade, like somebody in 50s or 60s. Now, even it has affecting people in second decade. Teens are having severe chronic backaches. So the latest statistics done in the United States says almost 1 in 3, 65 to 70% of the population in United States will come across chronic pain in their lifetime, once or several times. Of that 70%, 50% will be having very severe pain who needs help, like hospitalization or an invasive treatment techniques for them. Why so much? Why the burden is so much? And it is on the rise. Obviously, we can list out many reasons why the chronic backache is on rise. Again, we have to blame our quality of life, because if it is affecting the teens, then we have to realize there is something wrong in the way we live, like lack of exercise, and obesity is the biggest threat now. Like we have to watch for our back, watch for our tummy, watch for our waist. Lack of exercise, obesity, smoking. These three are the very commonest conditions causing back pain that affects age group from somewhere 15 to 80. Nevertheless, a significant population of patients will have chronic backache without any reason. That is very, very, very tricky. If you identify the cause, if you ask them, like they'll be their lifestyle will be very healthy, they will not be having any risk factors, but still they can get chronic backache. It is like how we get diabetes, we get hypertension, because they run in families. Like that, the low backache also runs in families. Unfortunately, even if you live a healthy life, sometimes we may get into this chronic backache at some point of time. So what we understand from this, or what the message as a pain physician we give after telling this is like, even with a healthy lifestyle, if someone can get back pain, It's a wake-up call for all of us to devise a lifestyle which is very healthy, which takes care of your body. We should take care of a body like a temple. Then I think we can at least avoid getting into a severe back pain in future. So that's about the chronic backache. If you
So
take the
what
younger population will be predominantly having the muscle related back pain or the disc related back pain. And if you take a geriatric population, they will be more having a degenerative spine disease. Like there are bones which are protecting the spinal cord, and we have joints in those bones. So those bones, those joints can get arthritic, and every movement can load that joint or unload. Whenever the joint gets loaded or unloaded due to any movement like forward bending, lateral rotation, turning, the joints loads and unloads, and that gives a severe backache. So it depends upon the pain generator, from where the pain comes. We have to tailor the therapy for the low backache pain.
so what would be the pain management strategies for low back pain, or does it need to be investigated first before therapy is given?
Yes. So clinical examination itself will give us 90 to 95% of the diagnosis. Very simple. There are various tests available for pain physicians to elicit and then arrive at a diagnosis. As I said, the spinal cord is divided into three compartments: anterior compartment, middle compartment, and posterior compartment. There are tests, clinical tests, simple bedside tests available to diagnose where is the pain generator. Is it coming from the anterior compartment, which is vertebral body, or the middle compartment, which is a spinal canal, or the posterior compartment, which is the facet joints? There are bones, joints surrounding the spinal cord. And obviously the disc, which is a cushion between the vertebral body, comes in the anterior compartment. So there are tests, very simple test, bedside test available to diagnose from where the pain comes from in any one of these components. So once we make a provisional diagnosis based on our bedside examination, we can confirm the diagnosis by imaging. One simple X-ray sciogram is enough to diagnose what is the predominant pain generator in the spine. And if you need little more information, or we have a luxury of doing a MRI, where that we can make even more clear diagnosis, or I would say to confirm your clinical diagnosis, we can do an MRI, and then that gives more information on discs, spinal cord, the nerves arising from the spinal cord, all those things. So once the diagnosis is made, then we have to start the treatment. In America and of late in Europe, any patient comes with pain, usually we know they all go to their family physicians, and family physicians refer a patient to a pain specialist, because pain specialists to do a 360-degree evaluation of the back pain, because they will not have a tubular vision. They will do a 360-degree evaluation of this low back pain and then arrive at a conclusion, and then initiate the treatment. Coming to the treatment part, we have two types. One is the medication, which is pharmacotherapy, otherwise called non-invasive modalities to treat the back pain. Another one is the invasive treatment. We choose the modality based on patient's clinical condition. If patient has got a very severe, acute severe pain, obviously we go to an invasive technique straight away without subjecting them to a non-invasive technique. In non-invasive technique, we have got medications, physical therapies, and other complementary therapies. So that's how a pain specialist evaluate a patient with chronic backache and then give them the choice. More than 90% of patients with chronic back pain are handled by, or can be handled or handled by pain specialists in developed nations, which is catching up in developing nations and in tropical countries as well. and the rest 10% of the patients needs surgical intervention because there are some conditions in chronic pain, backache needs surgical interventions. They come close to around 10 to 15% of the patients with chronic back pain. So that's how the algorithm goes.
So, in this interventional pain management for back pain, what are the procedures that are done?
As I mentioned, we have three compartments in spine. Let's take the posterior compartment because why I'm starting from posterior, because that compartmental back pain will restrict the mobility very badly, especially people above 60 and 70. Every one of them will be having that arthritis in their bones, the low back bones, which is surrounding the spinal cord. So it's going to be very difficult for them from lying down to getting up and getting them to lying down and standing to sitting. Any change of posture will be extremely painful for them, which again clearly states they enjoy a very poor quality of life. They'll be there once their mobility is restricted. Obviously, that invites a lot of other problems like obesity, depression. Once your mobility is less, we all know like what are the other allied problems we get into. So for that, what options we have in interventional pain is denervate the joint. As I mentioned before, it's a targeted therapy. We know the pain is coming from the joint. Identify those nerves, reach to that nerves with the image guidance, and ablate those nerves. So what happened that joint, we call it as facet joints for medically we call it as facet joints. So it gets denervated. It loses its nerve supply because, as I mentioned before, the nerves are the one which takes the pain signal to the brain and makes us feel pain. So once you burn that nerve, you are completely taking off the nerve supply to the joint. So the patient feel their back has become free. So that is for the posterior compartment pain. For the middle compartment pain, where there is a canal through which the spinal cord goes and along with its nerves. Once the canal becomes narrow, obviously there will be pressure on the spinal cord and its nerves. So the pain is because of the nerves. So we should not immediately jump into widening the canal, which is going to be a very extensive procedure. Once we decide to widen the canal, then we have to cut the skin, cut the supports of the spine, like the muscles. Muscles are the ones which are given to us, given by God to support the bones. But when a surgery is done, we have to sort of release that muscles and then reach the spine and then to widen the canal if the canal is so narrow, causing compression of the spinal cord. But the pain is coming from the nerves. So what we do is like, we call it as an epidural injection. Reach the canal through an image guidance with a specialized needle and then give a couple of medicines like local anesthetic, which actually breaks the pain cycle, and give good steroids, anabolic steroids, because they are the very good anti-inflammatories going to work on the nerves, which is coming out of the spinal cord, and especially on the nerves which are compressed by the tight canal. So once that nerve healing takes place and the pain cycle breaks with your lignocaine medication or the local anesthetic given along with your steroid in the epidural space, most of the back pain will be relieved. And then you have to subject them for lifestyle modification and physical therapies. This is for the central compartment. And we have got an anterior compartment, which I mentioned, the vertebral body and the disc. So disc, what happens as we grow, as we become more and more, as our age increases, I won't say elderly, as our age increases, the disc becomes little weak. We call it as degeneration, disc degeneration. It happens because the disc loses its hydration and it becomes weak. So it is like a punctured tire. So once you stand for the long time, like how the punctured tire will bulge out, similarly, the degenerated disc will bulge out when we stand for a long time. So that itself, due to the stretch, can cause pain in the low back, and the wide stretched disc will compress on the nerves which are coming out of the spinal cord and cause pain, radicular pain, which means the nerves are coming from the spinal cord, goes and supplies the leg until the toes. So this bulging disc, like a punctured tire, bulges out and causes pain because of its own stretch. And secondarily, causes a mechanical compression on the nerves that is exiting the spinal cord and gives pain in the leg as well. So we can reach out to those nerves, same with the image guidance with an X-ray. We call it as fluoroscopy. It is done in the operation theater with the image guidance where precisely the needle will be taken to a nerve which is compressed mechanically by those bulging discs and then again deposits medication. And mechanically also with volume, whatever the inflammatory mediators there, the chronic fibrosis there in and around that nerve root which is compressed by the disc will be released. We call it as adhesive lysis. So it helps by 2-3 mechanisms. One is the local anesthetic breaks the pain cycle, and the steroid what you give heals the nerve root. And third, the volume what we give, it releases the adhesions because of the chronicity. Thereby the nerve gets free and then the pain gets relieved. So this is the idea of doing the intervention in chronic back pain.
So I think this session has been extremely informative, and I think our viewers will be, it would be really, I think, very educational for our viewers that there are options to manage pain. Living with pain can be extremely challenging, both physically and mentally. So I would only say that if you are in pain, you have to talk to your doctor about a personalized pain management, seek specialist help, and then you can always, there are so many options now available, so that you don't need to feel stoic and manage your pain, live with your pain and feel depressed and anxious about it. But there are numerous ways that you must explore to tide over painful phases and live a happier and healthier life. Thank you so much, Dr. Anand Murugesan, for this wonderful discussion. And viewers, if you have any more queries, you can reach out to us. We're always there to answer your queries on all our social media channels. So take care and see you all soon. Thank you and namaste.
Thank you so much.